Vanakkam. There is a congenital condition on the hand that may not present at birth but may present a little later during infancy or sometimes even during puberty. That is camptodactyly. What causes camptodactyly? In fact, every single tissue around the proximal interphalangeal joint, starting from the skin right down to the collateral ligaments, can cause camptodactyly. But the commonest culprits are the flexor digitorum superficialis and the lumbrical muscles. We shall see all about camptodactyly, the different types and its management in this video. Camptodactyly or campylodactyly as it is sometimes called refers to a flexion contracture or flexion deformity of the proximal interphalangeal joint of the finger in an anteroposterior direction. Campylo refers to arched and dactylos refers to finger. This painless flexion contracture of the proximal interphalangeal joint of the finger, which is known as camptodactyly, is usually progressive and it occurs without intra-articular or peri-articular PIP joint swelling. It is also important to note that in camptodactyly, the metacarpophalangeal and distal interphalangeal joints are not affected, but compensatory deformities may develop. The concept of a congenital flexed finger was introduced by Tamplin in 1846, but the term camptodactyly was first used by Landozzi in 1906. As far as the cause of congenital camptodactyly is concerned, every single structure in the finger around the proximal interphalangeal joint has been implicated. The skin and subcutaneous tissues could be a cause either by deficiency or contracture within the dermis, or fibrotic changes within the subcutaneous tissue or fascia, or even contractures of the collateral ligaments or the volar plate. Musculotendinous anomalies around the proximal interphalangeal joint, like abnormalities of the flexor tendons, intrinsic muscles, either the lumbricals or interossei or both, or the extensor tendons, could cause camptodactyly. Abnormalities in the restraining ligaments like the transverse or oblique retinacular ligaments could be a cause, and even bone and joint deformities like atypical configurations of the proximal interphalangeal joint could be a cause of congenital camptodactyly. Even though there are so many postulated theoretical causes, the most common is an anomaly of the flexor digitorum superficialis FDS and intrinsic musculature, either the lumbricals or interossei. The flexor digitorum superficialis can be contracted, underdeveloped, or devoid of a functional muscle also, and the tendon may originate either from the palmar fascia or the transverse carpal ligament or the flexor retinaculum instead of a muscle belly. The insertion of the flexor digitorum superficialis may also be abnormal. It may be inserted to the proximal interphalangeal joint or even the proximal phalanx. As far as the anomaly of the lumbrical muscle is concerned, there may be an aberrant lumbrical muscle. We know that the normal origin of the lumbrical muscle is from the flexor digitorum profundus tendon, and the normal insertion is to the extensor expansion of the same finger. In congenital camptodactyly, there may be an abnormal origin from the transverse carpal ligament or the flexor retinaculum, and there may be abnormal insertion either into the metacarpophalangeal joint capsule or onto the flexor digitorum superficialis itself, or into the ring finger extensor apparatus, which is the neighboring finger, or even within the lumbrical canal itself. Since the insertion of the lumbrical is on the flexor side itself of the finger, it may lead to a intrinsic minus deformity and a shortened lumbrical. So when the metacarpophalangeal joint is flexed, the patient may be able to extend the proximal interphalangeal joint, but when the metacarpophalangeal joint is extended, the patient will not be able to extend the proximal interphalangeal joint. This abnormal musculotendinous architecture cannot elongate during the periods of rapid growth associated with infancy and adolescence, which creates a PIP joint flexion deformity during these particular age groups. There are many consequences of all these problems that we have seen. The first, of course, is a flexion deformity at the proximal interphalangeal joint. There may also be deformation of the intra-articular bone leading to a stiff joint. Prolonged flexion deformity of the finger at this joint may lead to deficient skin or shortening of the skin on the palmar side. With increasing age, the extensor mechanism becomes more insufficient, leading to a further extension lag. Congenital camptodactyly could be an isolated proximal interphalangeal joint flexion contracture, or the term can sometimes be used for those fingers where the proximal interphalangeal joint cannot be actively extended but have supple joints. In about 30% of children with congenital camptodactyly, we can elicit a familial history. In these cases, it is inherited as an autosomal dominant condition, and sometimes it may be associated in syndromes like the Holt-Oram syndrome and the Poland syndrome. In some situations, it can be sporadic. It is seen in less than 1% of the population. Most cases are mild and asymptomatic and probably do not warrant evaluation also. And this condition is bilateral in approximately two-thirds of the patients. As we have mentioned earlier, it is usually a progressive deformity, but it stops being progressive as skeletal maturity is attained. In congenital camptodactyly, functional deficit is mostly limited and therefore appearance is mainly the concern. In severe forms, however, functional deficit can be substantial, especially when more fingers are affected. The little finger is the most commonly affected in congenital camptodactyly, involving more than 70%, followed by the involvement of the ring finger. The other fingers are involved in less than 10% of patients with camptodactyly. Camptodactyly can be classified according to the clinical presentation or according to the time of presentation and status of the proximal interphalangeal joint. According to the presentation, patients with camptodactyly can be divided into three groups according to the classification by Benson et al. The newborn male or female patient with a camptodactyly of mostly the fifth or sometimes the fourth finger and sometimes all fingers comes under the classification of type 1. The adolescent, mostly female with sudden onset or increasing camptodactyly of mostly only the fifth finger following growth spurt, that is the prepubertal age, comes under group 2, and this does not improve and progresses to severe deformity. Type 3 refers to severe camptodactyly associated with other malformations. Fouché et al. Further subdivided this classification into four types. Type 1A, which refers to the early presentation, that is in infancy, and a stiff proximal interphalangeal joint. Type 1B refers to the early or infancy presenting camptodactyly with correctable camptodactylies or flexible joints. Type 2B refers to the pubertal presentation of the camptodactyly with stiff proximal interphalangeal joint, and type 2B refers to the pubertal presentation with correctable deformities. We had mentioned that camptodactyly could be associated with certain other anomalies or conditions. The commonest are craniofacial disorders like the orofaciodigital syndrome, the Freeman-Sheldon syndrome, chromosomal disorders like the trisomy 13 to 15, short stature associated with camptomelic dysplasia or mucopolysaccharidosis, or other conditions like the Turner-Kieser syndrome or the Zellweger syndrome. All these should be looked for when we come across a patient with camptodactyly. Clinically, we need to evaluate the camptodactyly by these 6 tests to determine the degree of severity. Can the proximal interphalangeal joint be actively extended while the wrist is held in a neutral position? Does skin blanching appear while extending the finger as much as possible at both the metacarpophalangeal and proximal interphalangeal joint? Does the proximal interphalangeal joint flex when the wrist and the metacarpophalangeal joint are extended, that is, the superficial flexor tenodesis test, can the proximal interphalangeal joint extend passively by the tenodesis effect while the metacarpophalangeal joint and wrist are held in flexion? Is the flexor digitorum superficialis of the little finger independently working from the ring finger? Routine AP and lateral views of the hand should be taken to evaluate the configuration of the proximal interphalangeal joint and the status of the surrounding bones. The lateral radiograph is the most revealing view for assessing abnormalities of the proximal interphalangeal joint. In long-standing cases, X-rays are abnormal and show changes about the proximal interphalangeal joint secondary to the prolonged flexion deformity. The proximal phalanx head will often lose its normal convexity and appear misshapen. The flexed middle phalanx base generates an indentation along the palmar neck of the proximal phalanx, and the base of the middle phalanx itself frequently appears flat and may be subluxated in a palmar direction. But seeing a patient with a flexion contracture of the proximal interphalangeal joint itself does not warrant to make a diagnosis of congenital camptodactyly, because there are so many conditions that can have this problem. It could be a pterygium syndrome where there are multiple pterygia, usually including the knee and the elbow, arthrogryposis where there is multiple joint involvement, waxy skin, underdeveloped musculature, and ulnar deviation of the digits. Boutonniere deformity also may look like camptodactyly, but there is a history of trauma and pain, joint swelling, and reciprocal distal interphalangeal joint hyperextension. In Beal syndrome, there is congenital contractural arachnodactyly, kyphoscoliosis, and external ear deformities. In Marfan syndrome, arachnodactyly without flexion contractures may be seen, loose ligaments, eye problems, and dissecting aortic aneurysm may be associated. As far as management of the camptodactyly is concerned, conservatism is the mainstay for treatment of mild camptodactyly. A contracture of less than 30 to 40 degrees does not interfere with activity or create a functional handicap. The patient and family need to be instructed to accept the deformity and avoid surgical intervention. Static splinting at night is recommended to prevent progression. But usually there is no improvement, or sometimes there is a progression of the deformity in 80% of individuals with camptodactyly. Severe involvement hinders activities and warrants treatment, although restoration of full motion is not a realistic goal. Bony changes further downgrade the expectation after surgery. The management can be non-operative or operative. Non-operative management of camptodactyly consists of three modalities: passive stretching exercises, splinting, and serial casting. Of these, splinting is the most commonly used modality. A splint should be applied for all patients with camptodactyly in which the proximal interphalangeal joint is not supple. The splint stresses the proximal interphalangeal joint gradually to as much extension as possible. It needs to be continuously applied for a minimum of 10 to 12 hours per day. A reduction to less than 30-degree extension lag is considered good enough to refrain from surgery. The duration of splinting therapy before further surgical treatment varies from 3 to 12 months. Some authors even consider an extension lag of 60 degrees as an indication for surgery. If the splinting program demonstrates a passively improved joint without improved active extension, or if the joint movement is not improved, surgery can be indicated. But as far as surgery is concerned, we need to remember that it is difficult to treat and inconsistent results have been reported. Superior results can be obtained in a motivated patient with a mild deformity. So the ideal candidate for obtaining good results with camptodactyly are young patients with supple proximal interphalangeal joints not able to extend the joint actively. Patients with stiff proximal interphalangeal joints, elderly patients, patients with a bony deformity on X-ray, and non-compliant patients or parents are poor candidates for surgery. Basically, there are three components for surgical management. The first is division of some or all of the offending agents, that is the fascia, skin, tendons, tendon sheath, capsule or collateral ligaments. Once these have been done, we need to do a reconstruction or augmentation of the extensor mechanism at the proximal interphalangeal joint, which can be done in the same sitting or in a different stage. The third option may be for bony procedures about the proximal interphalangeal joint where there is a deformity of the joint. So the basic options for surgical management of camptodactyly are release, reconstruction of extension, and bony surgery. The surgery of release is done by approaching the proximal interphalangeal joint with either a palmar or a mid-lateral incision depending on the magnitude of the contracture and the status of the skin. Planning a Z-plasty-like incision as shown in the diagram is ideal. After the release, it can be closed primarily or, if necessary, a full thickness graft or flap can be given. Once the incision is made, the degree of PIP joint contracture dictates extent of release required. Graduated release is performed until adequate PIP joint extension is achieved. Any abnormal fascia or linear fibrous bands are released during exposure of the deeper structures. Additional release of the flexor tendon sheath, the flexor digitorum superficialis, the check rein ligaments, collateral ligaments, and palmar plate may be necessary to obtain satisfactory extension. As this release is being done, the lumbrical should be explored along its entire length to assess for any abnormality. Any anomalous origin or insertion of the lumbrical or interosseous muscles or both should be resected. Traction on an anomalous lumbrical muscle will not result in PIP joint extension as it should happen normally. The lumbrical, as we have seen, may insert into the metacarpophalangeal joint capsule, onto the FDS or onto the ring finger extensor apparatus. All these sites should be explored to make sure there is no anomalous insertion. An anomalous palmar interosseous muscle can be found passing into the ring finger, although partial division of the intermetacarpal ligament may be required to completely assess its course. The flexor digitorum superficialis tendon is identified proximal to the first annular pulley or via the third annular pulley. Traction is applied to the tendon in a proximal and distal direction to assess its excursion and insertion. Deficient proximal excursion, that is when we pull the tendon proximally and make the finger flex, if there is a concomitant inability to flex the PIP joint, indicates abnormalities of insertion. This problem requires release of the FDS through the A3 pulley window. Lack of distal excursion, that is, by pulling the proximal tendon distally, if there is no good gliding, it implies proximal pathology and requires excision of the flexor digitorum superficialis. After release of the FDS tendon, the PIP joint extension is assessed. If adequate extension is achieved, the Z-plasty is closed. If there is any skin defect, it requires full thickness skin grafting. This example shows camptodactyly involving only the skin of the index, middle and ring fingers while the joint is involved in the little finger. Contracture release by serial Z-plasty was enough to achieve good results in the index, middle and ring fingers. Sometimes flap cover may be required. A cross finger flap can be done from the neighboring finger, but that leads to scarring of the neighboring finger also. This technique, described by Liao et al., shows a tongue-shaped flap taken from the radial side of the involved little finger to transpose and cover the defect on the volar aspect of the little finger after release of the contracture. The clinical results are also seen in this study. After release of the PIP joint contracture, the next step is reconstruction of extension at the proximal interphalangeal joint, that is, to provide active extension movements at the proximal interphalangeal joint. This can be done by means of tendon transfer. It is ideally done for Camptodactyly in adolescents who are unable to extend the PIP joint when the metacarpophalangeal joint is positioned in flexion. But the disadvantage of this procedure is that there is a risk of a swan neck deformity occurring because the tendon transfer may be too tight, and this may also lead to loss of flexion at the proximal interphalangeal joint. The procedure can be done using the flexor digitorum superficialis tendon, provided there is an independent FDS to the little finger and good distal excursion is present. By the transfer of the FDS to the extensor apparatus, there is a decrease in PIP joint flexion force and increase in the PIP joint extension force. The FDS is transected just distal to the PIP joint through a third annular pulley window and withdrawn into the palm proximal to the first annular pulley. The lateral band and central slip are isolated over the dorsum of the digit over the proximal phalangeal region. A tendon tunneler is passed from the dorsum of the finger into the lumbrical canal beneath the intermetacarpal ligament onto the palm. The tendon is passed through the lumbrical canal and attached to the lateral band and central slip via a weave technique. The tendon is tensioned with the metacarpophalangeal joint positioned in 30 degrees of flexion and the PIP joint held in full extension. It should never be over-tensioned. If an independent FDS to the little finger is not available, the flexor digitorum superficialis of the ring finger can be used for reconstructing little finger camptodactyly, or sometimes the extensor indicis proprius can also be used. After the procedure, skin is closed with a Z-plasty or a full thickness graft or a flap, as we have already seen. Postoperative immobilization is done with the wrist in neutral position, metacarpophalangeal joints in 70 degrees of flexion and interphalangeal joints straight. K-wire fixation is optional, and if done, it needs to be maintained for 2 to 3 weeks. Cast removal is done after 3 weeks, and a thermoplastic splint is applied with the wrist in neutral, metacarpophalangeal joints in 70 degrees of flexion and the interphalangeal joints straight. Subsequently, scar management and tendon transfer training are carried out. 6 weeks after surgery, light resistive strengthening can be started. When there is severe flexion deformity of the proximal interphalangeal joint with secondary bony changes, surgery for the bone is necessary. It can be done in the form of bone realignment with a dorsal closing wedge osteotomy of the proximal phalanx or a PIP joint fusion. An osteotomy corrects the posture of the finger and shifts the arc of motion. However, the overall amount of PIP joint motion remains unchanged. This may result in loss of full flexion and impaired grasp. PIP joint fusion or arthrodesis sacrifices all motion. The outcome of management of camptodactyly can be studied with regard to the outcome for splinting and the outcome of surgical management. As far as the outcome for splinting is concerned, Hori and colleagues reported on 24 patients with 34 fingers who underwent splinting protocols. The average follow-up time was nearly 4 years. 20 fingers had almost full extension, 9 were improved, 3 were unchanged, and 2 fingers became worse. The average flexion contracture improved from 40 degrees to 10 degrees. As far as the outcome for surgery is concerned, multiple surgical procedures have been reported for camptodactyly. Smith and Kaplan performed an isolated FDS tenotomy. The flexion deformity decreased by at least 33% in all fingers without a concomitant loss in finger flexion strength. Jones and Associates reported 6 patients who underwent FDS tenotomy combined with transfer of the tendon to the extensor apparatus. The residual average PIP joint contracture was 15 degrees with a range of 0 to 25 degrees. Complications occurring after surgery for camptodactyly should also be understood. There can result an injury to the neurovascular structures either from direct laceration, tension during extension of the digit, or subsequent scarring. Skin sloughing in digits with considerable contractures may be seen, and may need either a cross-finger flap or a skin graft. The next important complication may be loss of motion or flexion after surgery. This could occur due to the release of the FDS with subsequent scar formation within the flexor sheath, due to the concomitant PIP joint release resulting in adhesions and less movements, or even rarely complete PIP joint ankylosis. This loss of motion after surgery is a dreaded complication because lack of full extension is better tolerated than deficient flexion. So early mobilization should be instituted to get restoration of flexion. But we need to remember that return of flexion may be slow. It may take up to 6 to 12 months for the complete flexion to return. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about other congenital conditions like the cleft hand and congenital syndactyly. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery, and ethics.